Hi everyone, it's Friday, it's 1300 or 12 o'clock, 1 o'clock, therefore it must be coffee and chat. Yet again, I failed miserably to grab myself a coffee before we've started, and I haven't even got myself a water. My pint glass is completely empty. What is going on? So today, I'm really pleased to introduce you to Monica. We haven't seen each other either personally or virtually for some time, but we've known each other a hell of a long time. So I'm really glad that she's here to talk to us. And we're talking about data in the NHS. Now, those of you that know Explosive Learning Solutions know that we've been working with the NHS for the last few years, in fact, the last 4 years, on demand and capacity management. And obviously, data is a big part of demand and capacity management. So this for us is a really interesting talk to hear what Monica has been up to. She's always been far better at the IT and data than I ever could dream of being. I know there are quite a few of you on the line. Please, if you've got any questions for us, just pop those into the chat function. I'll pick those up and we'll take questions as they come in. We will keep to a time constraint. It's our promise always to keep this very organic and free, and we'll only talk for about half an hour, and then at about that half an hour point, I'll round us up and we'll start looking forward to next week. So, Monica, you're a little in the dark. I'm not quite sure why. But what have you been up to? What's going on? What's this amazing new model that you sent through to us?
Thanks, Kath. And yes, for those of you who are online, Kath and I probably know each other for about 30 years, but we'll just gloss over that. So yeah, I don't know why it's
old enough. We knew each other at school, didn't we, Monica? Yeah.
Of course, yeah, primary school. Yeah, no, that's just a grey cloud going over Yorkshire as outside. So I'm based up in Leeds, actually just outside Leeds on top of a windy hill. So that's probably the weather. So yeah, so for the last sort of 16 years since I left the army, I've been involved really in sort of the NHS, but in particular sort of cancer research as well, as covering a whole sort of range of data and information component sort of parts really. Some of that has been sort of frontline, working in an acute trust, actually the day-to-day sort of running of a hospital. Some of that has been at a regional level, and what kind of sort of secondary uses do we need to gather in order to do quality improvement, service planning, for whether that's for commissioners or providers, and actually some of that has been at a national level, whether that's actually through the NHS Information Centre, where I worked for 5 years, sort of running the National Dataset Service, or actually in more pure sort of research. And
it always alarms me how much of a deep specialist you are on these sorts of things. So it's been, 16 years just working in the NHS and specifically on data. And that patient journey, presumably for cancer, has been a big part of the last few years. And I know you'll have taken it on hugely. Can we just move on to the next slide, Sonia? Because so this is sort of where you've been, isn't it? It's looking at all of these different types of data that exists and trying to figure out if that makes a better outcome for patients.
Yeah, sort of, data is a word that people use in many sort of contexts, but for me, the patient is at the middle, of everything. The patient and the public. We're all data. Everything about us. Potentially you can look at lots of little bits of data, and people have become more and more sort of attuned to that. I think particularly over the last sort of couple of years since the new European regulation GDPR came in, and people have become more aware of sort of privacy arrangements and actually the value of data. Yeah, so in my current role, working for HDI UK, the HDI UK was set up sort of a couple of years ago, really, with industry strategy funds. So it is very much about trying to improve healthcare data for specifically sort of research, whether that's academic or commercial.
Oh,
And
okay. So it's extracting from the health service into another use. Is that the main aim?
yeah, it is. It's basically sort of that sort of research, and people can find it very sort of frustrating. I mean, you can't do research without evidence base, and because we've got an NHS, we've got a huge, rich sort of source of sort of data. And yes, we've got a whole load of rules and regulations, quite rightly so. But actually, it is it should be straightforward to be able to use this.
Yeah.
And as the Chief Data Officer, specifically sort of working on the HDR UK hub for cancer, because I've worked for Cancer Research UK and for the National Cancer Research Network, then it's a very complex disease, and actually it relies on sort of the clinical data, sort of whether people have appointments, whether they go to A&E, whether they're actually sort of admitted into hospital for treatment, whether that's sort of chemotherapy or whether it's radiotherapy. And there's a whole load of sort of data associated with that. People will have tests, they'll have blood tests, they'll have scans. And so you need to be able to access that pathology data, and the sort of the imaging that comes from scans. And now we're in a world of, sort of genomic medicine. Cancer is a genetic disease. So actually, and we've mapped the whole genome, so we ought to be a bit cleverer about it. Because in the past, essentially, we used to give, people big bucket loads of chemo and hope for the best. And the outcomes, without being too flippant of that, were only really about sort of 30% chance of survival. So since we've been able to sort of map the whole genome and look at targeted therapies, so we can see whether there's a gene mutation, then actually you can give people with more confidence drugs that are actually going to work. And so really what we're trying to do is improve access, improve quality, and also really importantly, ensure fair value. So,
What does that mean? What does that mean in human terms, ensure fair value?
Yeah, it's making sure that the NHS is not getting ripped off.
Okay.
Being brutal about it.
Yeah.
Because, we put a lot of effort. A large teaching hospital like Leeds Teaching Hospital that, is probably one of the biggest sort of in Europe. It's got thousands of beds. Just to do the central return for the cancer outcomes and services dataset, which is the mandatory cancer registration dataset, costs about £1 million a year for the amount of people that it needs to extract those data, curate it, do the data quality, do the checking, and actually send that into the centre. And they don't get much back for it.
Yeah, so is the issue a lot, I mean, remember in the good old days when we used to worry about data within the Ministry of Defence, a lot of the challenge was always about the data input and the quality of the input, and therefore it was, very difficult to manipulate anything downstream because the data input and the human element of that was never quite as good as you might wish. People's interpretation of what question they were being asked. Is that still a problem in the health service? Because obviously in demand and capacity management, which is where we've been working, there was quite a lot of challenge at first, making sure that people were using data input in the same way across the whole environment in order to be able to extract the similar type of information at the far end.
Yeah, I mean, it's got much, much better, particularly sort of over the last 5 years. I think if we're truly serious about digitization, then actually we've got to put the effort into having proper electronic patient records. So what does that actually mean? That means actually using a robust system, whether that's a homegrown system or whether it's a sort of commercial off-the-shelf sort of package that is actually sort of embedded in everything you do, so that when a doctor or a nurse or an allied health professional is having a contact with a patient, whether that's in A&E, whether it's in an outpatient attendance, or whether that's actually sort of, inpatient when they're in a bed or having surgery or whatever, then essentially, rather than writing it down on paper, they should put it into a structured format, into an electronic patient record.
And where are we at the moment with that electronic, human data piece? Because obviously at some stage there was, in your and my memory, we can remember the time where they were talking about putting all of your data on some type of card and that you would have access to that. So if you went to a different health facility, then your data would go with you and that could be plugged into the system and then used effectively. Where are we at the moment with this centralized system?
So that's moved on, and rather than, you can have a patient held record, but actually that's just as you just log on to your own sort of record. So GP records have always been very electronic. You know, when you go to the GP, they spend most of the time looking at the screen, but actually, and you have to use proper coding systems. So because you know, medicine is complicated, and so therefore you need you know, a comprehensive way of describing that, and those are referred to as clinical terminologies. The most accepted one worldwide is called SNOMED, which is systemized nomenclature of medicine, and I've been sort of working internationally to help to get that sort of, you know, implemented. And once you record it in a structured way, then actually then you can share it. So there's a big thing about interoperability. So you know, when somebody's been in hospital, so they've been in for an operation and then they get discharged, then an electronic version of what's referred to as their discharge summary automatically goes to the GP and into the record. In the past, that used to be a piece of paper or a fax, and then somebody had to key it in. So we've moved on. We've got sort of much better systems now. And once again, the use of standards, there's health level 7, which is the messaging standard for making sure that what you send from the hospital and when it arrives at the GP surgery, it hasn't lost that integrity of what it meant. And you haven't had
which is quite important.
Your right kidney taken out rather than your left kidney. So,
yeah, you know. I'm always far happier when they actually put the arrow on the leg that they're just about to extract.
Yeah, exactly.
So you were saying earlier that the rise in genetics has made a massive difference. So that again, I guess, is an interoperability question. So they've now made far more of a link between the genetic information and the clinical data.
Yeah, absolutely. So, you know, through sort of research, we've been able to identify, you know, what specific genetic mutations lead to certain sort of diseases. And actually, a piece of work that I was involved in when I worked at Cancer Research UK was called stratified medicine. So it is essentially about saying that a cohort of the population, you can actually then evaluate to see how many people have got this particular mutation and how many people haven't got it. So if you think about breast cancer, and people know about, you know, sort of being HER2 positive and getting Herceptin, so there's no point in giving you a particular drug like Herceptin if you haven't actually got a positive sort of result. And you can stratify your population so that actually you can target those, and that's referred to as molecular diagnostics. Because prior to that, it was essentially just a pathologist sort of looking down at a microscope at a slide and saying, oh, that looks like a certain kind of tumor. Oh, yes, you know, I'm being a bit flippant, but, you know, you can actually look at the digital signature of it, and it's lots and lots of ones and noughts and AGs and T's and C's, but turn that into a short report that goes to the pathologist, that actually then goes to, say, the oncologist, we're talking about cancer treatment, and they can make much better informed clinical decisions on the back of it.
Yeah, so they've got more data input coming into them on a routine basis in order to improve their outputs. Yeah,
you've got to turn it into information, though, and you know, we all know that continuum from data to information to knowledge to wisdom. And you know, it takes a few years to build that up, but giving people the raw data doesn't always help.
No, indeed. So I can see AI appearing in 2 of your areas, so radiology and pathology. What's the application of AI that they're looking at, and machine learning?
Yeah, well, actually, with radiology sort of images, you can train computers to actually recognize different sort of patterns.
I hadn't considered that.
And the accuracy of it is actually pretty good. And you know, we're doing some work in Leeds, and there's other sort of big cancer centres that are actually looking at the sort of the accuracy sort of that, and actually the way to potentially sort of improve, because the referrals that you get from a GP to a hospital, particularly in the context of cancer, it's referred to as a 2-week wait. It's one of the NHS England sort of targets that you have to meet. And, you know, in fairness, the GP will err on the side of caution in terms of a sort of, the risk factors, and this lump looks a bit sort of suspicious, we'll send you, to have it sort of tested and what have you. But actually the hit rate for that sort of, the amount of people who get cancer is only about 10%. And so there's 90% of people who spend a lot of time worrying about whether they've got cancer or not. For a mental health and that parity of esteem, then it's actually important. It's not a good thing. And also it takes up a lot of time at the other end in terms of having those scans, having those, sort of tests and everything. So there are opportunities to be able to apply machine learning in order to be able to reduce the accuracy, so that really the people that actually go into the system and further down are the ones who are going to benefit quicker and more effectively from the treatment. And actually we're not wasting the patient's time, we're not wasting the healthcare professionals' time.
It's a really interesting idea. I hadn't even considered patterns, which obviously it is. So it's a obvious candidate for machine learning, isn't it?
Oh yeah, no, there's some really effective sort of applications now sort of around that. It's not the be all and end all, and you've got to still have some clinical interpretation, and algorithms haven't had a good press over the last sort of few weeks, so that you've got to make sure that the human learning is brought into to anything that you do. But
change in process also always requires the humans in the whole system understanding what the change in process is, isn't it? You and I know this better than most. So
so it's basically there to help the the humans to do things better.
So it's an aid. How about the pathology piece? Where's the AI and machine learning in there?
Well, it's about moving to digital pathology on the imaging side of things, but also, sort of really sort of any kind of, process you can apply sort of machine learning really in terms of sort of, predictive sort of patterns. And you can also look at it from a population level. So one of my other hats, as if I didn't have enough to do, is as the exec lead for population health management for the Yorkshire and Humber Care Record. So this is a programme that was funded by NHS England over the last sort of 2 to 3 years for our population of 5.8 million people across the whole of Yorkshire and Humber, and actually taking the data out of sort of each of the systems, de-identifying that, applying the national opt-out if people don't want their data to be used for secondary uses, and actually looking at sort of trends, and looking at sort of, segmenting a population to see, what the kind of characteristics of that are. And you can essentially, you need a whole sort of richness of data in order to be able to sort of add to that. But pathology is always sort of really sat on the sidelines, and our pathology systems within the NHS can be pretty old and clunky, and so actually being able to integrate them more into our overall sort of electronic patient record is important, and then you can actually look
difference.
Make a big difference. Yeah.
And more people using these. I mean, you say on the top of that slide, this is both linked records and. Sorry, you said at the top of this slide that this is both linked records and longitudinal records. So, is there more work, or can you not even, you can't even necessarily divide the research? But is there more that's longitudinal work now, or is that not making any difference? So you can't make that division.
No, it's really, really important. What we refer to by longitudinal records is not looking at things in silos. So classically, you've had a data set about you at your GP. There are data sets that sit in the hospital. There are data sets if you have a community caseload, or if you've got sort of social care package, if you've got mental health sort of care and delivery as well. And they've been essentially sort of independent and not joined up. So a longitudinal record is actually one that recognizes you as an individual and essentially the pathways that you take in order to be able to look after you in a holistic way. It requires digital maturity, it requires interoperability, it requires, you know, those to be sort of digital. But where I was working last before I took up my current role was the CIO at Rotherham Foundation Trust. And we'd created a longitudinal record because we were an integrated trust. So we were responsible for both the acute side of things, the hospital side, and the community. So by default, we had to join those things up because it was our responsibility. And so we had a proper data warehouse that actually connected those things. Well, once you've done it for those things, you might as well join all the GP records as well. So all 30 GP records were linked and were viewable, and both adult and social care. I mean, Rotherham, you know, has been through a tough time over the last sort of few years with all the child abuse. And one thing that really came out of that was a very resilient workforce. So who absolutely recognise the need for sharing data for safeguarding. So that if somebody is
they were quite happy to stay in it.
Yeah. So actually, you know, all of the sort of parties involved, whether that was from the commissioning side of it or from the provider side of things, recognized that we needed a Rotherham health record shared to be able to look at those adverse events that if you look at in isolation, you know, doesn't mean anything, just somebody's come to A&E. But when you add that up and you see that they've been 13 times over the last sort of 3 months or whatever, and that they've had a, you know, sort of community intervention, and they've had all of these other things, there's something wrong here, and that flags up as a sort of a safety case.
And are you starting to see flags now as an automatic? You know, that's obviously a repeated visit, so there's a flag there, for, and presumably that then brings in other health professionals or indeed other professionals. Or are we still looking for flags across the board? I guess that as we do more research on all of this data, you start to look at different types of flag.
You do, and you start to be able to have that feedback loop to say, right, what was the outcome, and what was, and do that classic cause and effect kind of analysis and feed it back in so that you learn from it and then actually recognize what are the real triggers and what are the ones that are potentially just sort of noise in the system. So it is about that sort of learning, sort of better care management. And there are a number of models that are used across the NHS for this kind of individual and service planning, you know, better care loop. We've got population health management sort of models where we look at risk stratification and managing care, and then sort of analysing the outcomes and then feeding that back into the system.
So I know you've been working a lot with cancer. Are they using cancer, because I know that you came from cancer research as well, are they using cancer as a prime area that we're making sure that we've got it right in one area before we start looking at other medicines, or is every medical area going up in this sort of big data way?
Yeah, absolutely. Every sort of specialty, you know, is having its investment, and HDI UK has 7 hubs, and there's a cardiovascular one. There are various other ones as well. But we've been recording cancer data for about 70 years, and cancer generally tends to be ahead of the pack. Because it's a complex disease and there are lots of component parts, but we've had cancer registries in place, and they literally used to be nurses with clipboards writing things down and, you know, putting that together and then putting it onto you know, onto cards and having that in a card index, and then you move that into an electronic sort of format. Now, it's integrated. We're capturing it, and we can use that for secondary purposes and beyond. And as you said earlier, Kath, you know, the advent of genetic and molecular medicine has been a quantum leap, because that's actually a new form of medicine, and that doesn't happen very often. You know, the International Classification of Diseases is only at version 10, and it's been around 400 years.
So how often do are we in a position with research work in particular where we are then sharing some of that data internationally? Because obviously there is the ensuring fair value then does start to really kick in. So we're actually learning from an international perspective as well, from a data position.
Yeah, I mean, international clinical trials have been going on for many, many years, and that always happens. But internationally, we work together. Yeah, absolutely. And I referred to some of the sort of standards, HL7 and SNOMED, without getting too techie about it. They're both international communities. They're called standards development organizations. They're not-for-profit organizations, and it's done a bit like the sort of League of Nations. You only pay on a per capita rate depending on your GDP. So it's very much recognizing that, this is a global issue and we should do it together, and the World Health Organization has a big part to play in it. But ultimately, healthcare happens locally. It happens at place. It happens in your town that you live in. And so you've got to have these layers of the onion to be able to do it. To be able to connect these things together, which is why you need those linked longitudinal records in order to be able to have a truly digitized system.
Yeah, but it's quite, so what's the next stage?
Oh, goodness me. Well, it's really to get it better. It's to get it better. Yeah, it is continuous improvement. I think it's also about making sure that we have translational medicine, because sometimes researchers can be terribly sort of parochial and highly competitive, and they don't really want to share it with other people, and they don't really think about what the applicability is back at the front line within the NHS. So that's a really important part, is that translational medicine is the term that actually, whenever you're designing something from a research perspective, that it's got an applicability back in the front line. And once again, that's about sort of fair value and improving quality and access. I think the final thing I would say, it's got to have trust. So you've got to have really good patient and public involvement. And certainly at DataCan, we've got patient advocates who sit on all of our governance boards, who are involved in everything that we do, co-design, co-development. We may be doing something completely legally, but if it hasn't got the public trust, don't do it.
But I think what you were saying about Rotherham and resilience is so important, and I think that's something that, the whole resilience trust piece and people's understanding of what could actually happen with this data is so critical. As you rightly said, doesn't matter whether it's legal or not. If you haven't got that trust, then it's not a great thing to be doing. I knew we'd run out of time, and guess what? We have. Really great seeing you. Thank you so much for your time. Huge amount of information there. I'm really good to see you, and hopefully we'll get to meet each other again soon in person, either up in Leeds, because I do occasionally work up there, or indeed when you're back down in London again. But you take care, and guys and girls, we've got another session next week. We like to roll these out on a weekly basis, as you all know. It's on social value next week. A close friend of ours in Oxfordshire is coming on to talk about social value, something I feel absolutely passionately about. I'm hoping that we might have another guest speaker, but he hasn't quite confirmed yet. So it's on social value, very, very different as normal from today's session. Monica, thank you so much for your time. Best of luck for all of it, because frankly, the more improvements that you can make and more continuous improvements you make in this space, the better for all of us, I suspect. Really good to see you, and take care, everyone. Bye now.
Thanks very much. Cheers, everyone. Bye.